everyone, welcome to TryRight. This is Pack 365. Myself Srija. So today in this session you're going to learn about CPT coding guidelines regarding radiology. So how codes are classified in the radiology section, you're going to learn all these guidelines in detail in this session. So what are the specific guidelines regarding radiology? So here are some headings and subheadings. So what does this mean? The radiology section is divided into headings, which are the main categories, and subheadings, which are the specific areas. So some subheadings have a asterisk symbol. So these have the special rules or instructions you must read before the coding. So always read these notes, the guidelines before codes. CPT rules come before the numbers. So what are the special notes and guidelines? So some subsections, they have the special instructions that apply only to that subsection. So those notes appear before the list of the procedures. And code ranges may appear out of the numerical order or be repeated if needed for the clarity. So do not assume CPT codes always appear in the perfect numerical order. So what are the major radiology CPT subsections? So here they are. So the first one is diagnostic radiology, diagnostic imaging. So the code ranges are 70,010 to 76,499. So this subsection, it includes X-rays, CT scans, MRI and fluoroscopy. So for example, it's a chest X-ray, CT abdomen and MRI brain. So most commonly they are used, radiology codes are found here. And the second subsection is diagnostic ultrasound. The code ranges are 76506 to 76999. So they uses the sound waves, which is there is no radiation, and also examples like pregnancy ultrasound, abdominal ultrasound and Doppler studies are performed in this section. So radiological guidance. So this is used, these codes are used whenever imaging guides a procedure, such as biopsies, injections and catheter placement. For example, CT guided lung biopsy. So guidance codes may be separately billable unless bundled. Breast and mammography. So they include the screening mammograms, diagnostic mammograms and 3D tomosynthesis. So screening versus diagnostic mammography codes, they are different. Bone or joint studies. So this section, they include bone density and skeletal imaging codes. For example, osteoporosis screening. And radiation oncology. The code ranges are 77,261 to 77,799. So they include planning and delivery of the radiation for cancer. And also these are used mainly by the radiation oncologist, not general radiology. And next is the nuclear medicine. So nuclear medicine, the code ranges are 78,012 to 79,999. So this section, it uses radioactive tracers and also functional imaging, like how the organs work. So what are the examples? PT scan, thyroid uptake study and also the bone scan. So therapeutic section, the code range is 79,005 to 79,999. So treatment using radioactive substances, for example, radioiodine therapy for thyroid cancer are coded under therapeutic subsection. And what is radiology CPT? So what is a big concept here? So radiology CPT codes, which ranges from 70,010 to 79,999. So generally it's a 70K series. So they describe the diagnostic imaging, image guided procedures, radiation based treatments. So they are used by the physicians, hospitals and medical coders. So what is the purpose of this radiology CPT? Billing, documentation and reimbursement. So radiology as a medical specialty. So radiology, it's a branch of medicine that uses imaging technology to diagnose the disease, guide the procedures and treat the conditions. So the common imaging modalities mentioned are X-ray, ultrasound, CT or CTA, MRI or MRA and PT scan. So not all radiology uses radiation. Ultrasound and MRI are radiation free. And these are the types of scans which are included in the radiology CPT section. So the first one is X-ray, which is also called as a plain radiography. So X-ray uses the electromagnetic radiation. It is a non-invasive procedure. It produces black and white images. So why bones look white? Because different tissues absorb radiation differently. So bone contains calcium, so it absorbs more X-rays and it appears white. So air indicates black color and soft tissue indicates gray color. Whereas if the bone contains more calcium, it appears white in the X-ray. So what are the clinical examples? Chest X-ray, fracture imaging, and abdominal obstruction. So most plain X-rays fall under 70,010 to 70,350 and also the similar ranges. So next is CT scan. So CT scan is a computed tomography scan. So what CT really means? It's a specialized X-ray. It computer combines images to create the cross-sectional views. So it can image the organs, bones, vessels and tumors. So what are the key advantages? It is very faster than the MRI and also it is excellent for trauma and emergencies. So CT codes, they vary based upon the body part with or without contrast. CTE, computed tomography angiography. So what makes CTA different from CT? It focuses on blood vessels, it uses the contrast material and it shows arteries and veins clearly. So they are used to detect the aneurysms, stenosis, blockages and vascular malformations. So CTA, they always involves the vascular imaging plus contrast. So imaging is not equal to the guidance. So diagnostic imaging requires separate CPT codes. So the imaging used to guide a procedure means radiological guidance codes are involved here. So documentation is very critical here. It must include the technique, body part, contrast usage, interpretation and report. The next procedure is MRI. So what is MRI? Magnetic resonance imaging. So what it is? It uses a strong magnetic field plus radio waves. It produces high detail images of the soft tissues. There will be no ionizing radiation. It is more safer than X-ray and CT. So this is very best for brain and spinal cord, joints and ligaments, soft tissue tumors. So MRI is preferred when soft tissue detail matters more than the speed. So MRI codes, they differ by body part with contrast or without contrast, sometimes with and without contrast. So MRI is magnetic resonance angiography. So what it is, MRI technique, it is focused on the blood vessels. It may use the contrast, but sometimes it does not use the contrast. So it is used to detect the aneurysms, vessel narrowing, as well as the vascular malformations. Ultrasound or sonogram. So how it works? It uses the high frequency sound waves. There will be no radiation and also real-time imaging of the organs. So this is very best for pregnancy, abdomen scanning like liver, gallbladder, kidneys, pelvic organs and also thyroid and soft tissues. So ultrasound, it is the safest first-line imaging, especially in the pregnancy. So what is in coding pearl here? It must include the images as well as a written report. So next is Doppler or duplex scan. So what is the main purpose of the Doppler or duplex scan? It studies the blood flow, not just structure. It measures the speed and also it measures the direction of the blood flow. So what are the common uses of Doppler scan? DVT, deep vein thrombosis, carotid artery disease, peripheral vascular disease. So duplex is equal to B mode image plus a Doppler flow. And next, PET scan. So the full form is positron emission tomography scan. So what makes PET special? It uses the radioactive tracers. It shows the metabolic activity but not the anatomy. It produces the color images. So this is mainly used in the cancer detection and staging. So treatment response monitoring, some neurological disorders. So PET shows how cells behave, not just how they look. So PET codes, they are often bundled with CT. And now how the CPT book arrangement is done, which is very important. So diagnostic radiology section for imaging. So codes are arranged in anatomical order, not modality order first. So what is the anatomical sequence? Head and neck, chest, spine and pelvis, upper extremities, lower extremities and abdomen. So always locate the body part first, then choose the modality. So what are the order of the codes under each subheader? So within each anatomical section, CPT follows this fixed modality order. X-ray, next CT followed by CTA, MRI, and finally MRA. X-ray CPT codes guidelines. So X-ray CPT codes, they are based upon the number of views, not on how many images a machine took. So CPT arranges the X-ray codes from minimum views to maximum views. So how X-ray codes are structured in CPT? So a lower code, it gives a fewer views, whereas a higher code, it has a more views. So CPT uses a standalone codes which have fixed views. So minimum of views codes. So for example, here is a wrist X-ray, which is very important. So the codes which are available in CPT is CPT code 73100, which is for radiological examination of the wrist 2 views, whereas 73110, it is for 3 views. So these two codes cover all the wrist X-ray situations. So scenario A, only one view is taken here. So what's the problem? CPT code 73100, it requires a 2 views. So but only one view was done. So how do you code? What was the correct code given for this? So you have to use CPT 73100 code with assigning modifier 52, in which we assign this 52 for reduced services. As there is only one view done, so we have to assign the modifier 52 in this scenario to give the proper accurate coding. And scenario 3, in scenario B, we have 3, 4 or more views taken. So do we change the code for 4 or 5 views? No. So what is the correct coding here? CPT code 73100 with no modifier. So description says minimum of 3 views. So any number which is greater than or less equal to 3 is already included in this code description. So more views have the higher code once when the minimum is met. And in the scenario C, we have the bilateral wrist X-ray. So both wrists imaged, both right side and left side. So the option 1 is modify 50, which we assign for bilateral code. And the option 2 is site-specific modifiers, assigning modifiers RT and LT. So you have to use one method only. So you have to follow the pair rules. Some prefer RT or LT over 50. And you coding 73110 for only 2 views is a error. And also coding separate codes for each extra view is also an example of an error. So using modify 52 when views are more than required and using both 50 and RT, LT together is a big medical error in the medical coding. You should not follow these error guidelines. You should always give the accurate coding. So X-ray CPT for repeat procedures and modifier. So when the same X-ray procedure is performed more than once on the same day, so you must decide, was it repeated, who repeated it, was it the same or different views or anatomy. So each answer leads to a different modifier. So what are the repeat procedures, 76 or 77? So a repeat procedure means we have same CPT code, same body part, same day, which is performed again because it was clinically necessary. And modifier 76. It is a repeat procedure by a same physician. So modifier 76 is used whenever same doctor, same X-ray and same day. It was performed on the same day. So example is breast X-ray. We have two views, one at 10 a.m. here and other at 11 a.m. here by the same physician. So you have to assign 73100 for first view. And for second view, you have to add the modifier 76. So next is modifier 77, which is repeat by a different physician. So you have to use when same CPT, same body part and same day, but it is performed by a different physician. So you have to, for example, here, there are two views of the wrist X-ray, one at 10 a.m., one at 11 a.m. by a different physician. So for the first view, you have to assign the CPT code 7300. And for the second view, you have to assign the same CPT code with modifier 77 and modifier 59, distinct procedural service. So what modifier 59 means? So modifier 59 tells the payer, yes, these look similar, but they are truly separate services. So these are generally used when different views are taken in the different sessions and on the same day with same anatomy or otherwise a different anatomy. So major versus minor. Same anatomy, same day. So the scenario is one is taken at 10 a.m. breast X-ray with 3 views and the other is 11 a.m. breast X-ray with 2 views. So which is done on the same wrist on the same day. Why not modify a 76? Because views are different, CPT codes are different. So what is the correct coding? You have to assign 73110 code for the first view and 7300 for second code with 59 modifier, as second view is different. It's a minor study, whereas minimum 3 views, it's a major study. So same CPT but different anatomy, also they modify 59. For example, right wrist X-ray, left wrist X-ray, same CPT, same day. So if RT or LT not sufficient or payer requires separation, you have to always assign modify 59 to that CPT codes. So next, coming to overlapping anatomic locations. So what overlapping means? Some body parts share the anatomy. Hand, fingers, foot to toes. So CPT often considers this related. So billing both on the same day can look duplicative unless you show they are distinct. So when modify 59 is allowed on the same day, different view sets, separate medical necessity, and they are the distinct studies which are not just extra pictures. And here's an example. There is an 3 views of hand and 2 views of finger, which is an X-ray, which is performed on the same day at the different timings. So how you will assign the code? So the correct code is assigning 73130 code for the first view, and for the second view 73140 you have to assign the modifier 59 because these are distinct procedural services. So don't use 59 if finger views are simply a part of the hand study. And next is combination CPT codes which are bundled and do not unbundle. So if CPT provides one code that already includes in multiple areas, you have to use it. So never split into separate codes just to increase the payment. So the common combination examples are ribs with chest. So you have to use the combination code 71101 and 71111. And hips with pelvis, you have to use 735012, 73523 code ranges for these combinations. So you have to avoid the error like coding ribs and chest separately when a ribs with chest code is available. So when there is a combination code, you have to code the combination code itself. You should not assign separate codes. Modifier 26 and TC. So professional versus technical part. So what they mean, 26 is a professional component in which interpretation and report is done by a specialist. And technical component means including of the equipment, technology and the supply. So when to use physician office or independent radiologist, you have to usually use 26 modifier. If the hospital owns the equipment, hospital bills TC, whereas the radiologist or the specialist bills 26. And global service, in the presence of the global service, office owns both. So there will be no modifier used here. And there is a critical reminder. Views are not equal to images. So CPT selection is based upon the number of views, whether it's anterior, lateral or oblique views, but not the number of pictures or digital images. So here is an example. If there is 20 images from 2 views, you have to still code for 2 views only. So code by the views only, but not by the images. And CT scan CPT codes guidelines. So how CT codes are arranged here? So CT codes, they follow a 3-step pattern for each body part. First is without contrast, second is with contrast, and third is with followed by without contrast. So how to choose correctly? So if only non-contrast, you have to pick without contrast code. If only contrast, you have to pick with contrast code. So if both done in the same session, pick up with and without contrast code. Do not build 2 separate codes. There will be a combination code which is given as with followed by without. So here's an example. So CPT always allows the standard CT codes, CT structure codes for each body part. So 71250 code, which is for CT chest without contrast, and 71260 for CT of chest with contrast, 71270 CT of chest with followed by without contrast. So never build two CT codes for the same site on the same day. So if both non-contrast and contrast are done, you have to use one combined code. So in the morning, CT chest without contrast is done. In the evening, CT chest with IV contrast is done. So what is the correct code? You have to assign 71270 CPT code. And the combination of 71250, 71260 assigning is very wrong. So you have to give a combination code for with and without contrast. So next is CT abdomen and pelvis. Combination codes versus individual codes. So here are available CPT codes. The individual codes is CT of abdomen 74150, 74160, 74170. And for CT of pelvis 72192, 72193 and 194. So these are the combination codes. These are preferred when both are done on the same day. Whereas there are individual codes 74176 for without contrast, 74177 with contrast and 74178 with and without contrast. So if abdomen and pelvis CT are done on the same day, you have to use only the combination codes. So for example, CT abdomen with contrast, CT pelvis with contrast and the same day. So the correct code in this scenario is 74177. So the wrong code pickup is 74160 along with 72193. So combination codes, they exist to prevent the unbundling abuse. And CT with 3D reconstruction. So that is 76376 versus 76377. So when 3D can be built. So 3D reconstruction, it is not automatic with CT. It must involve independent workstation, separate post-processing and distinct physician work. So what are the CPT choices? So 76376, 3D reconstruction not requiring the independent workstation. 76377, 3D reconstruction requiring independent workstation. So what is the billing rule here? If 3D is documented, you have to build a CT code plus 76376 either or 76377. Repeat CT on the same day. How to code correctly? Scenario from this slide is CT done without contrast. Later on the same day, CT repeated with IV contrast. So the same anatomical site. So how do you code this scenario? You have to use one CPT code describing with and without the contrast. So for example, CT chest without contrast in the morning and CT chest with IV contrast in the evening. You have to assign the code 71270. So what counts as a contrast study? Very important. So which are considered as contrast? IV, intravenous, intra-arterial, intra-articular and intrathecal. And what are not considered as a contrast? Oral contrast and rectal contrast. So these are not considered as a contrast study. So CT abdomen with oral contrast only. This is coded as without contrast. Next is CTA scan CPT codes guidelines. So how CTA does work? CTA codes, they are single standalone codes. They come after regular CT codes in the CPT book. So all the CTA codes are with IV contrast and it includes image post-processing. So CTA it's a combination of CT plus contrast plus post-processing in the one code. So why 3D codes? 76376, 76377, these are not built with CTA. So CTA inherently requires vessel reconstruction, 3D reformats and specialized post-processing. So therefore, 3D is already bundled into CTA CPT codes. So do not build 76376 or 76377 with CTA codes. So if it's CTA, 3D is already paid for. And part 2 is MRI scan CPT code guidelines. So MRI follows the same contrast logic as CT, as the computed tomography. So without contrast, with and without contrast. So what is an example? MRI of brain. So 70551, this is the code for MRI of the brain without contrast. 70552 MRI of the brain with contrast. 70553 MRI of the brain with and without contrast. So same day MRI contrast rule. If MRI is done without contrast, so then it is repeated with the contrast on the same day. So you have to build one code in this scenario with and without contrast code. So do not build two separate MRI codes, same like CT. And what is the important exception of the MRI of spinal canal? So for MRI spinal canal and contents, CPT does not follow the 3-code pattern. Instead, each contrast option has its own separate CPT code. 72156 for MRI spine without contrast, 72157 MRI spine with contrast, and 72158 MRI spine with and without contrast. So why this exception exists? Because spinal imaging involves multiple levels, cord, nerve roots, CSF, and complex protocols. So CPT keeps this separate for accuracy. So spine plays by its own rules. And MRI of upper and lower extremities. So why there are two sets of codes? So MRI extremity codes, they are divided based upon what is scanned, like joint study, non-joint study. So this is very important because you cannot mix them for the same structure. And upper extremity MRI codes. CPT code 73218 to 73220. So these are used when MRI is done on arm, forearm, like soft tissues, muscles, tumors, infections, and hematoma, etc. So if the report mentions shaft, muscles, or soft tissue mass, you have to think it as a non-joint. Upper extremity joint study. CPT code 73221, 73223. So these are used for shoulder, elbow, and wrist. So the code descriptions are 73221 for without contrast, 73322 with contrast, and 73223 with and without contrast. So if the report mentions ligaments, labrum, rotator, cuff, cartilage, you have to think it as a joint MRI. And what are the lower extremity MRI codes? For lower extremity non-joint studies, the CPT codes are 73718 to 73720. So these are generally used for thigh and lower leg, which is a calf. And you have to assign 73718 code with without contrast MRI, 73719 with contrast, and 73720 for with and without contrast. Whereas coming to joint study, CPT codes used here are 73721 to 73723. So these are generally used for hip, knee, and ankle. So 73721 for without contrast, 22 with contrast, and 23 for with and without contrast. So here note regarding modifier 59. So here is a scenario, MRI of shoulder and elbow, same extremity, same day. So even though both are joint studies, they are distinct joints. So what is the correct coding? You have to assign 73,221 and 73,221 code for with modifier 59. So why modifier 59? Because it tells the payer these are separate distinct procedures but not bundled. Without modifier 59, second code may be denied. And then MRI scan CPT codes guidelines. So which is a big one. What is MRI first? It's a magnetic resonance angiography. So it studies blood vessels but not organs or joints. So what is the key rule here? MRI codes, these are usually standalone codes and they are not bundled into MRI codes. So what is the MRI code structure? Using the contrast logic. So almost all the MRI codes follow this pattern. 70547 without contrast, 70548 with contrast, and 70549 with and without contrast of MRI of the neck. So if both pre-contrast and post-contrast images are done, you have to always choose with and without contrast codes but not the two separate codes. So what is the rare scenario here? So in rare cases, there are three codes. First standalone code followed by two intended codes. So this usually refers to complex vascular imaging where one code represents the primary MRI, additional codes represent the separate vascular territories. So this is advanced billing and usually follows the payer-specific guidelines. And coming to 3D codes here. So why they should not be billed with MRI? So what are 3D codes? 76376. This is a 3D rendering without image post-processing. 76377. It's a 3D rendering with image post-processing. Without image post-processing and with image post-processing. So these codes, they describe post-processing of the imaging data, 3D reconstructions. So what is the key rule here? Do not bill 76376 or 76377 separately with MRA codes. Why? Because MRA already includes 3D reconstruction as a part of the angiographic study. So billing 3D separately, it's meaning a double billing. And surgery related radiological supervision and interpretation. So what does this mean? Some surgical or interventional procedures, they include imaging, physical supervision and interpretation of the images. So these S&I codes, these are not in the surgery section. They are found in the radiological section of the CPT. So what are the examples? Angioplasty, stent placement, embolization, vascular catheter procedures. So you have to always check, does the procedure code already include S and I? If it is included, you do not code separately. So what are the image guidelines codes? Where they are listed. So all imaging guidance codes, these are found in the radiology section, including ultrasound guidance, fluoroscopic guidance, CT guidance, and MRI guidance. So these codes, they are add-on codes and they are built with surgical procedures whenever they are allowed. And what are the important image guidance CPT codes here? So A, ultrasound guidance, 76937 for vascular access guidance, 76942, non-vascular guidance, biopsy, injection and aspiration. So what is the documentation required here? Real-time imaging, permanent image saved and needle entry is visualized here. And example is central line insertion for the code 76937 and thyroid biopsy for 76942. Next is fluoroscopic guidance. So CPT codes which are used for vascular procedures 77001, 77001 for non-vascular procedures, and for spinal procedures it is 77003. And for dialysis, for example, dialysis catheter placement. So you have to assign 77001 code as it is a vascular procedure. For joint injection, you have to assign non-vascular procedure code. And for epidural steroid injection, you have to assign the spinal code. So next is CT guidance 77012. And this is CT guidance for needle placement. So for example, CT guided lung biopsy, CT guided abscess drainage. So remember, this is not a diagnostic CT, it's a guidance only. And MRI guidance 77021. This is for MRI guidance for needle placement. So examples are MRI guided breast biopsy and MRI guided tumor specialization or localization. So one guidance code rule here is here. So only one imaging guidance code per procedure. So even if ultrasound plus fluoroscopy is used, you have to code only the primary guidance modality. And what is the linking guidance codes with surgery? The golden rule is imaging guidance codes are built only if the primary procedure code does not already include the guidance and proper documentation exists. So if guidance is bundled, do not bill it separately. So these are the important imaging guidance CPT codes. So this is for today's session. I hope this session has helped you. So the next session, you're going to learn some more CPT guidelines of the radiology CPT section. Thank you.